Okay, it's 5 minutes. Let us start. Welcome, everybody, and a particular warm welcome to the panelists who, at very short notice, accepted the invitation to discuss the hot topic of second-line therapy in primary biliary cholangitis. I'm afraid we have lost one panelist to acute disease. Christophe Corpechot is not able to join us today. He gave me his key messages, so that will be my role to, in between, say maybe his key messages. And I welcome the 4 other experts: Angela Leberg, who is the patient representative on the ERN management board and the patient representative in the PBC working group and the lead of the patient organization ALBI in France, who will give us or try to give us the patient perspective. Then Alessio Gerussi, who is one of the 2 disease working group leads of the PBC working group working in Milan, and Adriaan van der Meer in Rotterdam, as the other disease working group lead in the PBC working group, and Michael or Michael, depending on whether we speak English or take the original name, Trauner from Vienna, who has a long time track record on working on bile acid receptors and cholestatic diseases. The aim of this webinar is to discuss, and I'm sure we will all have differing views, to discuss the indications and possibilities for second-line therapy in the light of the new recommendation of the EMA, which at this stage is just a recommendation. Whether this recommendation will actually go into effect depends on the official procedure at the European Commission. And as far as I know, there is a rule of about 2 months or so on a time window until such a decision is made, which gives everybody time to think about it for a little time period. And maybe, Angela, I can start with you to ask to what extent you have heard reactions in the patient community, and maybe you can ask, as a representative patient, ask the questions to which you want answers.
Thank you. So first, I would like to congratulate ERN to organize this webinar, because it's destabilizing when we receive a news that a drug is recommended to be take over the commercialization. And it's important that experts discuss and explain and have the occasion to see the future and to speak about second-line treatments. So from a patient perspective, I would like to ask a question for you too, for you all. In your clinical management, which criteria do you use to say a patient is stabilized, the disease is progressing, or if it is possible to regression of the disease? So how do you see and how do you evaluate in your today practice in your clinical situation? I have this question.
Yes, I think I would interrupt you now, because you may have lots of questions, but we have to take them one by one. And this is already an extremely difficult question as to how do we really measure disease progression, disease activity in this disease, and to what extent is a surrogate marker or some other marker really helpful. And let's just at the beginning stick to the alphabetical order. Alessio, I take the name alphabetic, Adriaan, sorry. I can also do it the other way around next time.
So thank you, Angela, for this question. I think that in clinical practice, we do have good surrogate markers like ALP, bilirubin, gamma GT. We measure liver stiffness. So we have numerous means to assess fibrosis stage, compensation of liver condition, and how the disease progress over time. And many of these markers are also used to assess response to first-line treatment and second-line treatment. So ALP is the cornerstone of that kind of measurements. And the data that supports the prognostic value comes from large international centers, multinational studies, and it is clear from these studies that the higher the ALP, the higher the bilirubin, the worse the prognosis. And I think this is difficult to dispute at this stage.
Adrian? Adrian?
Yes, I had to unmute myself. Thank you for the invitation. Yeah, I don't have much to add. I think to Alessio's comment regarding alkaline phosphatase, although the hepatic transaminase should not be underestimated, I believe, and the body of evidence being retrospective is just so enormous that I think this is an important cornerstone at anno 2024.
I will have a question to at least both of you, but I will first listen to Michael's answer also. Michael.
Yeah, also from my side, it comes down to liver enzymes and liver stiffness, both for risk stratification and also following patients. Although, in terms of reduction, I think alkaline phosphatase and also I would agree transaminases are also important because they reflect hepatocellular injury in response to cholestasis. But the reduction in liver stiffness are a little bit, let's say, less robust and operator dependent. I think it's very good for baseline stratification. In terms of reduction, I rather rely on liver biochemistry. And of course, also calculating scores, globe PBC score.
The liver enzymes, I of course think that we can measure sort of more accurately, which doesn't mean that they give a more accurate answer. It's always tempting something where you have sort of very exact numbers to look at them closely. Now it's a pity that Christoph is not here because he just published that nice paper on the role of liver stiffness as a prognostic marker, which probably was very impressive and compares well to the studies that he has also coordinated in PSC, where liver stiffness proved to be the best marker and better than biochemical markers. The question I have to all three of you is, you are mixing in your answer parameters that are probably activity parameters, like liver enzymes, and parameters that are more a result of the liver injury, which is bilirubin as a functional impairment or liver stiffness as scarring. So
can we comment?
Yes, please.
Yeah. No, I think you are right. So there are two things, like the basis in hepatology. I think it's grading and staging. And I would consider the liver enzymes as a sign of the grade of the disease, and the liver stiffness measurements are as a new way to stage the disease, where we used to rely on liver histology. And it's a little bit more down the line. So basically, the treatments that we have been using so far, they influence the grade of the disease. And through this process, you hope in the end that the stage of disease will at least stabilize, but this is something you are less likely to measure on the short term. It would be more of a long-term effect of treatment. As we have seen throughout hepatology, if you are able to reduce the activity or remove the etiology of liver disease, then you can get stabilization of fibrosis, or even depending a bit how well you can stop liver injury from continuing, you can get regression of fibrosis, which was a dogma that was not possible in the past. Yes. So those are indeed two different things which measure different aspects of liver disease.
Okay, Michael?
Yeah, I think liver stiffness is great for risk stratification in terms of response to treatment, in contrast to, for example, viral etiologies, or also alcoholic liver disease with more data, that a 25% reduction, for example, would translate into meaningful clinical endpoints. We don't have that data in PBC yet. I think in PBC, I would be more confident that the same is the case with other, more patchy diseases or other things, such as in PSC play a role determining stiffness. I would be a little bit less hesitant, but I think the role of FibroScan at the moment is more risk stratification rather than monitoring response of the disease. And part of that is mainly due to, you want to make a decision within 3 or 6 months, and whatever you measure with FibroScan within this period of time, I'm, less comfortable with accepting changes within such a period of time as being clinically robust.
And do any of you think that liver biopsy, Adrian already referred to histological changes, liver biopsy should play a role into helping to decide how aggressive you should give the drug treatment?
I think Alessio wants to answer that. In clinical studies, yes. In clinical practice, no.
I think we're such a small group, you can just start talking, actually, Alessio.
Okay, so I agree with Michael. So we know that the role of liver biopsy is different from the past in PBC. We have in Europe the recommendation from EASL that stated against liver biopsy except from specific conditions and clinical situations. What I wanted to mention is probably non-invasive measurements and biomarkers like liver enzymes and liver stiffness do not capture ductopenia, bile duct loss. That is something that is important in primary biliary cholangitis. We do see difficult to treat cases, progressive disorders that are very ductopenic, and these patients probably are difficult to capture with the instruments that we have. That said, probably liver biopsy is not important from a clinical practice point of view in terms of assessment of response to treatment. I envision liver biopsy as supported also by EASL in those cases that are more difficult, like in those with a very inflammatory phenotype, also because in that case, as we all know, it's very difficult to understand what is PBCAH variant, and there's a lot of discussion and the Delphi ongoing on that. So liver histology in that case, we know, can play much better role.
Yes, and Alessio, you are doing this wonderful initiative from the ERN trying to define what the variant syndrome or what that strange thing, autoimmune hepatitis, PBC overlap really is. And probably most of us would agree that a biopsy is needed for that. And then different therapeutic decisions are taken. Angela, you got a complex answer to your question. So liver enzymes, in particular alkaline phosphatase, seems to be a very important basis for making a decision, but every patient obviously needs to be looked at individually with looking at these various parameters. Does that answer your question?
Yes and no, because if I make a comparison with PSC, I know that today we are speaking about PBC, but if we think about PSC, for example, UGCA treatment, even though biological markers are reduced, it is not totally considered as a effective treatment for this disease. So there is a difference between PBC and PSC. So sometimes it can be a little confusion for us patients. So
okay, I will pick up that point and make it a little bit even more nasty question to the panelists. So in PSC, the data that improving liver enzymes with UDCA is not convincing, but most of us give it. How convincing are the data that in PBC response to UDCA is important? I remember the very early trials that showed us this effect only in stage 1 and stage 2 PBC, but we now apply it to all stages of PBC.
Perhaps I can answer this question, as I was part of the real-world study to show what I think is a causal relationship between UDCA use and improved long-term outcomes. Obviously, the randomized trials which have been performed in the past, they were limited by patient numbers, by follow-up, number of events. So it's difficult to, that's exactly the same thing that we are experiencing now. It has been difficult in the past to show in a randomized setting the benefit of a drug on a slowly progressive disease. It took us, I think, 30 more years in the field, because only long before I even entered the medical school, to gather sufficient numbers of patients together in data sets from real world experience to be able to show a strong association between the use of the drug in this time we're talking about UDCA on solid clinical endpoints, transplant-free survival. And you need a lot of patients because you want to adjust these effects for all the potential confounders which might influence this relation. We have done this by collaborating internationally, combining data of more than 4,000 patients, and their use of UDCA was associated with quite a strong benefit on the long term.
And if I understand the data correctly, there is good evidence for that. There is also evidence that even if alkaline phosphatase is not improved, patients benefit, but they benefit less than the ones in whom it improves.
Yeah. So within the same analysis, we divided those who were treated according to their biochemical response, and most of the listeners will know there are these different response criteria, but basically it didn't matter how we categorize patients based on which response criterion that we used. It was always the case that if you again adjust for confounding factors, patients who have an incomplete response to UDCA, so they do not fulfill the criteria, the biochemical criteria of response after 1 year of treatment, had a better outcome than opposed to patients who were not treated. And we're talking here about 4,000 patients, hundreds of events, 10 years of follow-up on average. So quite solid real-world data. And if we even continue and we assessed patients who did not have any biochemical response in terms of, and then I really mean no decline in alkaline phosphatase, no decline in bilirubin, but the benefit was still there, and that would be in line. Evidence is getting less strong, obviously, if we move here towards these populations, but it would be in line with alternative modes of action which have been described for UDCA, apart from only reducing cholestasis, which is most easy to measure in clinical practice.
Okay. So Alessius, your hand is just still up from.
Yeah, no, just wanted to comment on the role of ALP as in PBC as compared to PSC, and I agree with what Adrian was saying, and just wanted to answer Angela. I mean, PBC, PSC, very different cholestatic disorders, of course, and while in PSC, ALP is characterized by a fluctuation and due to bouts of cholangitis, a very different natural history and disease course. In PBC, it is much more stable in its behavior. So that's why we manage, when we reach the large cohort of patients, to model it in so nice fashion. Just wanted to say.
Okay. So I return to Angela. You have other questions to ask? Otherwise, I will have lots of questions.
Of course, I have questions to ask. As you know, PBC patients, they are not very young, so they have other diseases. Sometimes they can have autoimmune diseases, but also other type of chronic diseases touching the majority of population compared to the same age. And do you consider, how do you do to manage the patient, taking into account the global health condition, knowing that the patient is taking many treatments and having different symptoms and different, I would say, the difficulties and impact in the life? How can you manage this in your practice and care, to avoid having explosive cocktails that sometimes patients are afraid of taking drugs, and they are very concerned about?
It's a complicated question. I will start. Adrian, you probably have the best overview of the global PBC study. How well do you know the comorbidities and the co-medications of the global PBC population?
No, I don't. These are obviously data which were gathered, at least when I was working with the global PBC data set back to the time, already some time ago. So these comorbidities are not included. I must say, from clinical practice, obviously there are other autoimmune disorders which might accompany PBC. There have been data on this, that it's quite frequent, but that is not influencing the prognosis of patients. On the other hand, in my opinion, and we have some evidence for this, is that on average, 55, 60-year-old females with a liver disease we diagnose early, they show relatively good health behavior, as opposed to many other of our liver patients, which might benefit their prognosis. And that's what we do see if we look at it, for instance, with responders to UDCA, that if we compare them to the general population, age and sex mix, that they live longer lives as opposed to the general population.
I think it's may I interrupt you briefly? I don't know how many of the listeners are patients and how many of doctors. I think it's an extremely important message. I mean, we all agree that PBC is an annoying, serious, long-term disease, but at the same time, I think it's important to repeat the message that the overall prognosis is quite good. The life expectancy of the vast majority of PBC patients is quite good.
Sorry, that's not what I was meaning to say. This is in a subpopulation with a complete normalization of alkaline phosphatase. This is the population in which we see this. Then you select those with the best prognosis who do quite well. But I think today's topic was more focused on those who do not have the good prognosis.
Absolutely, yeah.
Okay.
And before we go to definite second-line therapy, I would like to address one specific problem, which I think all of us have a little bit ignored lately, that the hypercholesterolemia of PBC. As an older hepatologist, I have gone through the different phases of whether hypercholesterolemia in PBC should be treated or not. Is it just a secondary symptom of the disease because of the cholestasis? Is it a risk factor for cardiovascular disease or not? Then for a while it was said, well, because the hypercholesterolemia has only developed later in life, and because these are mainly women, the risk is not very high. Then there were later data saying, oh, hypercholesterolemia, even if it comes at a later age, is a risk factor. So should we address hypercholesterolemia more actively, and isn't cardiovascular morbidity and mortality an important risk factor in PBC, all PBC?
Yeah. So I believe that you mentioned very well that there was in the past this understanding of maybe having hypercholesterolemia something different in PBC as compared to other people, I mean, general public. I think that today we have to stick to cardiovascular guidelines also for our PBC patients. So they don't, I don't think they have a specificity. We need to address their cardiovascular risk in a more active way than we did in the past. So there is no protection. We have evidence also from population-based data that there is a cardiovascular risk associated with high cholesterol in PBC patients.
So you would say the indication for statins should be the same as for any other person?
Yeah, this is what we also said in the recent position paper from the Italian PBC experts.
What do Michael and Adrian think?
Yeah, I totally agree. Actually, when you, for example, look at the waiting list mortality in PBC, the main cause of death is cardiovascular mortality, which tells me that we've overlooked that issue when, managing patients before. Of course, that's the fraction which is progressing. I mean, the hypercholesterolemia in cholestasis, of course, is something totally different. That's lipoprotein X, but still, we have the overlap with MASLD, with metabolic comorbidity, and the young woman. I certainly don't want to see, LDL cholesterol going up and HDL cholesterol going down. So we actually, I think statins definitely should be used according to guidelines. Unfortunately, statins themselves, we looked at that in a small pilot study, thinking that it might impact on PBC, does not seem to have altered the course of PBC itself, but that's, I think, quite evident in the meantime. I think the issue of comorbidity is extremely important. Also, renal safety. What about a patient with impaired renal function due to age or to cardiometabolic comorbidity? This is something we always talk about bone and as extrahepatic manifestations, but I think kidney, cardiovascular system is equally important. Of course, we take care of thyroid issues and bone issues, but that's something which, especially in young patients, I think the lipid issue is not as trivial. Just saying it's not MASLD and let's not care about that would be wrong. Having said that, any strategy reducing bile acid synthesis by any FXR agonist or by any FGF mechanism would increase LDL cholesterol, because you just simply downregulate the LDL cholesterol receptor when you inhibit bile acid synthesis, because cholesterol builds up. So this is biology which you only can overcome by giving a statin.
That already moves us to obeticholic acid as one principle. Before I will come back to the FXR stimulation. I saw Adrian agreeing with both of you on the statin rule, and I would ask him first. Statins can also elevate liver enzymes, so that can make the picture more confusing. So, what is the time scale? You have a new patient with PBC, you give UDCA and want to see a response. And if you see a good response, you're happy. If you don't see a sufficient response, you think about second-line therapy. When would you add the statin, and will that confuse your assessment of this?
Potentially, if there are, of course, increasing liver enzymes due to the statin. So this is all treating of long-term risk. I would wait until the PBC management is more clear before just adding a statin, I must say, and especially if you consider an off-label add-on therapy for a patient, or you already foresee that this might be a high chance that you would need such a consideration, then of course there's at least in the Netherlands we have off-label basal fibrate available, which can also impact the cholesterol levels, and then it's really an individual treatment decision what you would do with any remaining cholesterol levels.
We will come to that in a minute, and one patient rightly wrote also in the questions, when do we come to the question, what should a patient who is on Ocaliva do now? We will come to that question in a minute. Let me quickly, on the way there, return to Michael Trauner and the theoretical advantages and disadvantages of FXR receptor-directed therapy.
Yeah, one certainly is, restoring bile acid homeostasis by repressing bile acid synthesis and promoting bile acid uptake. Part of that is FXR itself. Part of that is indirectly by inducing this intestinal hormone FGF19, which then, reinforces this loop of suppression of bile acid synthesis. But certainly a very important mode of action is also anti-inflammatory effects, for example, by inhibiting NF-kappa B, and also antifibrotic effects. There's some controversy whether these antifibrotic effects are directly mediated by stellate cells. Recent data suggest that FXR is also expressed in stellate cells. Many previous studies have not shown that, but quite honestly, the recent studies are quite, let's say, technically well confirmed. So we have an anti-cholestatic, anti-inflammatory, and antifibrotic effect. Having said that, that's a little bit a uniform theme for nuclear receptor biology, that you restore metabolic homeostasis and counteract inflammation. So those mechanisms are not exclusively seen with FXR, although they are more in the bile acid space. But anti-inflammatory effects, for example, you also see with other nuclear receptor agonists, including the various PPARs.
And I understand that for obeticholic acid, there is also systemic immunosuppressive or anti-inflammatory effect. There's a nice paper, I think 8 years ago or so, that experimental autoimmune encephalomyelitis, so an animal model for multiple sclerosis, can be suppressed by obeticholic acid.
Right, yeah. So that was, one of the ways when designing all the non-steroidal FXR agonists, the hope was, to get rid of the pruritus and get rid of the lipid changes. The lipid changes, I explained to you, this is just simply bile acid biology, which you cannot overcome. And also the pruritus with the IL-31 story seems to be a uniform FXR phenomenon, what it looks like. So it's basically a general principle, and obviously there's also very nice data from the lab of Alexander Mietke, preclinical data, that you seem to need this broad anti-inflammatory action to reverse some of the biology in cholestasis. So when you just simply refine that by restoring bile acid homeostasis, for example, with these intestine-restricted agonists, you basically may lose this systemic anti-inflammatory effect, and that may become a disadvantage. But as I said, the hope was to get a profile which is less side effect prone, which at the end, it's also not really true. It depends on the dosage and on the affinity of these receptors, to which extent you suppress bile acid synthesis, thereby increase LDL cholesterol or induce pruritus.
So in other words, you are not surprised, or you're thinking that such a drug will have multiple effects. Some of them you can foresee and others you can't really foresee.
I am a little bit surprised. I also thought that the non-steroidal FXR agonists would be more of a game changer. Another thing is that especially obeticholic acid is undergoing enterohepatic circulation, which has the benefit, of continuous exposure of the system. The downside is, of course, then, you might have a higher risk of accumulation or dosage issues because it's recirculating and not rapidly metabolized. So there's also always a trade-off. When you make, let's say, compounds less side effect prone, you lose some of the activity and vice versa. And at the end, it also comes to dosing, because the relative affinity of some of the FXR agonists is really very different. For example, tropifexor, which is a non-steroidal FXR ligand, has a IC50 in the single-digit nanomolar range, which is extremely potent. Yeah, I mean, others are in the micromolar range. Yeah.
And what is your assessment of the possibly upcoming drugs?
I think the way I see it, one is moving a little bit away from intestine restricted ligands more to systemic ligands again. And there are different avenues, of changing the pharmacodynamics of these drugs. But I think it goes back to a more systemic exposure with FXR ligands. And we'll see also with the PPAs, the question is also, do we need a broad activity or do we want to make a very specific targeting of one specific isoform? Both has advantages and disadvantages.
So let's get to the key question, and I start with you, Michael. Now, if you have a patient who did not respond to primary therapy sufficiently and was put on secondary therapy with Ocaliva, I know there could also be a reason why you put them on the fibers and so on, and I know that each of you does it a little bit differently. But a patient now comes to you and says he has heard of the recommendation. What would you tell this patient?
Quite honestly, at the moment, I would not recommend to switch. I still would say, okay, we have an approved drug which has been shown effective. I assume in the specific patients which we are discussing, issues such as pruritus or lipid changes are not an issue, are effectively handled by statin co-treatment or dose adjustments. So I'm a little bit hesitant of out of principle now, switching somebody who obviously has benefited from a drug, because I believe in the real life data, quite honestly. I also have co-authored the papers on the real life data as a disclaimer. There's also data from Chris Bolus on antifibrotic and anti-inflammatory data in terms of histology. So the drug certainly works. It's the question of tolerability and safety issues, and that I think the decision is on an individual basis, as you've indicated, and also Adrian. Many centers here in Europe already used fibrates before FXR ligands, such as obeticholic acid, were available and had quite a good experience. And also the administrative issue in terms of reimbursement is less of an issue. But I think it is a pity to lose a drug, and maybe this is also the discussion, which in my eyes has shown efficacy in real life data if it's well tolerated on an individual basis.
I think we will all agree that it's a pity to lose a drug in an armamentarium or for a disease for which we have very, very few options. But even though we see that as a pity, we don't really know all the consideration that may have led to this. So the question is not, even though people are asking that question, it's not for us to be better than EMA. It's for us to see what do we do with the patient now sitting in front of us. What advice would we give to that patient? And one of the options, of course, is to enter the trial that's going on with the triple therapy, but that's only available in a few places. So, Adrian, what would you tell your patient?
First of all, it's not about trying to be better than EMA, but I do think that we are allowed to critically appraise any policy leading to the discontinuation of a drug which is experienced to benefit patients in terms of the evidence out there, albeit from real world cohort studies. So for my on the other part of the question, so I'm in the Netherlands and we don't have obeticholic acid available. So the daily impact of this EMA decision for the situation in the Netherlands is at present not that large. I had only bezafibrate available, off-label use, and I'm in a healthcare system and a healthcare culture where off-label use is quite accepted. That might not be the same everywhere. So I will just continue for my patients with trying to treat them with bezafibrate, even though we experience treatment cessation due to side effects or incomplete response. And yeah, as Michael pointed out, then it would be great to have an option with another mechanism of action.
Thank you very much. I will come back to your experience with bezafibrate. I think that's important. And in your answer, you raised another extremely important point. And people ask different questions of what is the role of the ERN. One of the roles of the ERN is trying to achieve equality across Europe. And interestingly, we don't have it. So in some places, you can't have bezafibrates. In other places, you can't have obeticholic acid. Now, so places will be affected differently by this recommendation, depending whether it comes to a decision. But it is actually quite striking that the legal situation actually demands an equality for all European patients. But the factual situation is quite different. We have the same with the bile acid absorption inhibitors in pediatrics, where in some countries you can't have it. And I think that is a serious problem that we will need to address. Alessio, I go to you. You have obeticholic acid in Milan. So you have.
Yeah, so in Italy, we have a very large cohort of patients treated with OCA. The recapitulate study that showed the safety and efficacy from the real world data on OCA comes from Italy. So the decision has a huge impact, I think, in terms of daily practice. What I suggest, I would not recommend an automatical switch. So I agree with Michael Trauner and Adria van der Meer. I would not. And another important topic is that if we switched automatically from OCA to beza, we probably would consider beza a drug that is in a way safer and or more effective. And we don't have clinical trial evidence on hard outcomes for bezafibrate, like we don't have, and this is something that we should be aware. I mean, also for the upcoming drugs, this is a topic. This is the hot topic. How can we evaluate what is a good drug for second-line treatment in PBC? Maybe it's not the topic of today's webinar, but it is important, as Adrian mentioned, that we as a community work productively and actively on that, just not to lose options, therapeutic options that could be useful for our patients.
I think it's an extremely important scientific and also politically scientific question, because this was one of the earliest drugs that was got a conditional license on the basis of a surrogate marker. And if that decision after a number of years with the follow-up studies and whatever the reasons for the decision have been, that's of course a big disappointment to everybody involved, both the patients and to scientists and obviously to the company. So I will turn to you, Alessio, in a minute about triple therapy. That is an option that Adrian does not have. So maybe, Adrian, you can tell us a little bit more about your experience with bezafibrate. So I understand from your first answer to Angela how you select a patient for bezafibrate. What would be your contraindications of bezafibrate, and what would be your warnings to patients when you start the patient on bezafibrate?
So, first of all, you determine the optimal treatment goal for the individual patient. And as the field moves forward, I think treatment goals are not the same for everybody. And so we have normalization now for a subset of patients, I think, and otherwise in other patients, the traditional response criteria might be good enough. And then if the treatment goals are not fulfilled with UDCA alone, then I take them along in the evidence why bezafibrate might be an alternative off-label option for them, and explain to them the potential side effects of the drug, but also the potential benefits based from real-world data, and the randomized data on the alkaline phosphatase, which I consider to be a good surrogate. And I explained to them the possibility of drug-induced liver injury, which has been described up to 10% in the real-world cohorts, which is one of the. Yeah, I think in the UK experience it's about 5 to 10%. We have seen it in the Netherlands. We have seen it in the Netherlands as well. A little bit. It was a little bit lower than that. It was couldn't collect DILI as an endpoint ourselves, but we have patients stopping bezafibrate because of at least the fear of drug-induced liver injury due to an increase in liver enzymes, which is a sort of a proxy perhaps, but it was stopped early. And in fact, the early treatment stopping rates in our first Dutch experience, about 320 patients, was 24% after 1 year. And it is exactly the same cumulative stopping rate as in the UK. And obviously, this is the very, very first experience in the Netherlands from the first patient prescribed bezafibrate onwards. So we hope to see that with time, this drug is used better and we are more used to the benefits and we might manage side effects a little bit better so that the stopping rate will go down. And there have been patients starting bezafibrate because of itch and they might never have initiated bezafibrate with the intention to do this on a long term. So this influenced this number as well. But in the end, I think the data show that bezafibrate is not the option for everybody, and that there is something else needed as well. And then I monitor kidney function, or at least creatinine, which might be kidney function, might also be that creatinine is released more from muscle due to the fibrate therapy. But especially the older patients, I'm a bit afraid of this, and if I see a signal here, I might reduce the dose to see whether I can treat the patient with a lower dose without this sign of increasing creatinine. And otherwise, I stop.
That takes up one of the points that Angela made about comorbidity and especially in the elderly population. Michael, I think you also have bezafibrate experience.
Yeah, we've quite honestly, so we use bezafibrate in most patients as first line treatment because also,
first line treatment?
Second line treatment, sorry, as first line option is in the second line treatment. So I have to adhere to the exact nomenclature and mainly due to the antipruritic effect. But I confirm what Adrian says. It's not trivial that we see discontinuation in the range of 7 to 10% for the reasons which is stated. I mean, the creatinine change is a pharmacodynamic effect, which we know from the diabetes study, from the field study, but still, monitoring also kidney function and GFR and cystatin, if that's available. I think in somebody who already has impaired kidney function, we certainly monitor that as well. And so the safety issue, I mean, all the studies which have been performed so far were not designed. The phase 3 study is not giving you a reliable safety signal. And I think this 10% discontinuation rate also from the UK. And I think the same was also in this Japanese data showing the survival benefit. I think also it was between 7 and 10%, something in that range. So it's not that everybody being placed on fibrate will be on that without problems forever. That's also something to keep in mind. And maybe, a distinction factor about the other people's, maybe their safety is different. So that would be one of the interesting questions from my side for the future as well.
Yeah, that would be a key question for the future. The Japanese often use fenofibrate, don't they?
Yeah, that was mixed pheno and beta. Yeah,
which is and the US also doesn't have bezafibrate. So Alessio, do you have bezafibrate available, and do you have patients on triple therapy?
Yeah, so Beza is available as off-label drug. So triple therapy has been used in Italy a lot, especially in difficult to treat cases. So just to give some context, after the approval of OCA became the first second line drug in the treatment pipeline, in the treatment algorithm. So that's why also many Italian hepatologists felt on the safe side to treat patients with the approved drug rather than on a labeled drug. And then, of course, there is the itching, and there is maybe still incomplete response because we aim for normalization nowadays, as Adrian also mentioned. And then comes triple therapy, like adding on top of UDCA and OCA bezafibrate. And of course, we don't know the medium long-term safety data on these strategies, and there is also a clinical trial ongoing, which is also good. But there are important real-world data on this strategy. And of course, the combination of beza and OCA could, counterbalance, the possible effect on itching from OCA. And and then I wanted also to comment just briefly on the DILI. So we have also, we don't have that magnitude probably, but we do have DILI from bezafibrate. And maybe that's something that we need to consider, especially in that orphan population of the PBC with inflamed phenotype, or PBC-AIH, or PBC with more pronounced elevated AST and ALT, because probably in those cases, beza make the clinical scenario more complex, like a raised ALT and AST is more difficult to interpret because you have to make some differential diagnoses about what is going on.
And that's where your Delphi work comes in as to which patient should really receive immunosuppression. And we may be in a hazy area here, realizing, as we discussed before, that OCA was also an immunosuppressive drug. So maybe we have already been using it in the past as a partly immunosuppressive drug. So the old question of whether immunosuppression is justified, I think, is a very similar question to the one that is now discussed in the context of OCA, because the general consensus, even though we have very few data, was there are so many side effects in long-term immunosuppression, and it's not such a aggressive disease, so maybe it's not justified to give immunosuppression, even though the few studies that are there, at least for budesonide and so on, show a benefit. So when you consider the possibility of immunosuppression, you would, at this time, not with the Delphi process not finished, you would recommend liver biopsy, wouldn't you?
Yeah, for sure. But at the end of the day, I think that the second line treatments like obeticholic acid showed also promising effects also on AST and ALT in PBC with inflamed phenotype. So the liver biopsy is essential, but we still don't know how to interpret like interface hepatitis in our PBC patients, right? So it's still a difficult topic.
Okay. One more question back to you, Michael, about the pharmacology. Bezafibrates were originally developed to have a benefit on hyperlipidemia, but did not show to have a survival benefit. Hyperlipidemia is a possible side effect of obeticholic acid. Do you think that the triple combination will have a good chance? I mean, we will hopefully see it, and hopefully that study will continue, not be affected by the EMA decision, and hopefully the company will continue that. But what do you think?
I think it's an interesting synergistic combination, also in terms of, the lipid issue, the pruritus issue, and also some synergistic effects in terms of mechanisms of action. I mean, one has to keep in mind that FXR is inducing PPAR expression also. So also the bezafibrate, although it's acting not only through PPAR alpha, but also through the other PPAR. So it's really a pan-PPAR agonist. It will be exciting to see whether also the mechanism of action of bezafibrate may be expanded. So I see some interesting synergistic rationales for a synergistic mechanism of action. for the combination. And certainly when it comes to combination therapy, for example, we don't have any experience about the new people ligands yet, how to combine them. So that's certainly a benefit that we are collecting these data already for bezafibrate together with obeticholic acid.
Very good. We are close to 1 hour. I will ask all of you for kind of a closing statement.
Thank you for the organization of this webinar. And I think this is it's important to continue the discussion because we probably will have to reconvene very soon.
And we all agree it's a disappointment to the field altogether. Adrian.
Yes, I completely agree with Alessio that if you now have a patient on OCA which had a good indication and it's tolerating the drug well and is benefiting from this biochemically, I would not stop this until you are forced. And right now we don't know at the moment what the option will be in the short term in terms of regulation, but also in terms of compassionate use. So for now, I would just continue with the drug if the individual is taking it well.
So it sounds as if we have to reconvene in 2 months. Yes, Michael.
Yeah, nothing to add also from a said before. I mean, when it comes to which drug do we primarily use for non-responders, as I said, similar to Adrian, I mean, we have Ocaliva or obeticholic acid available in our country, but in our center, because we have more long-standing experience with fibrates, fibrates are the first line, second line treatment, and maybe this the current EMA recommendation is having most impact probably in that space. That probably de novos started patients will be probably more skewed towards the fibrate space at the moment, but they certainly would not discontinue patients. And also, I think it's important to keep this option also in light of triple treatment and other, new combinations.
But it's very interesting that even in this expert group, there are such different practices depending on your national regulations or depending on local traditions, as you just said, and it shows us how limited our knowledge really is and how much work there is still to be done. I'm sorry, Angela. Please give us a final patient perspective or comment.
I would say it's so complicated, the management of a disease that is considered as simple, like PBC. And in the end, it's not so simple as it for patients that are not totally responded to UDCA. And so I would think that early diagnosis, we should really fight for early diagnosis to begin the treatment as soon as possible. That I guess the chances to succeed the treatment are higher with early diagnosis. Then to reinforce the idea of the need of having experts treating complicated PBC patients, because sometimes PBC patients are not seen by experts, by experimented doctors, clinicians. So it is very important to for patients to be followed up with really experienced clinicians. And concerning drugs, of course, we want to have drugs that cure, which is not the case for our chronic diseases, but that are more effective and less bad effects in the health, I would say. It is obvious, but
no, it's obvious, but it's often ignored. It's very important, that final statement which you have made also in other occasions. Patients want the disease cured; they don't want it slowed. And you didn't also address a problem that we haven't been addressing today, but which is also very important, that the quality of life, fatigue, none of these drugs really address the most disturbing symptom for a large group of patients, which is fatigue. So yes, I think we are in a disappointing phase of PBC care and research. So I'm extremely grateful to all of you. I'm well aware that we couldn't find the highly satisfactory answer that we really wanted, and only could give some encouragement in this situation. I hope we could give some encouragement, and watch this space for hopefully more and better news in the future. So thank you very much, and see you soon.